All right. Hey, everyone. I think we're going to go ahead and get started. Thank you for joining us. My name is Laura McGarry. I'm one of the PGY4 Einstein residents. It's my pleasure to introduce Dr. Josh Cohn this morning. Dr. Cohn completed his residency at University of Chicago and subsequently went to Vanderbilt for his fellowship training. He has a busy practice in Philadelphia now in urology and female pelvic floor reconstruction at Einstein, which is home to Moss Rehab, which is a top-ranked rehabilitation hospital. He always gives interactive and inspiring talks to the Einstein team, and we look forward to hearing his talk and learn more from him today.
All right, thanks, Dr. McGarry. I want to thank you all for being here and thank UCSF for the effort that they put in keeping resident education up during this time. So I hope, if I get this working, no disclosures. What I hope to do over the next 45 minutes and then in the question and answer session is review some of the basic neurophysiology associated with neurogenic lower urinary tract dysfunction, help you understand how video urodynamics helps us in the diagnosis and then targeted management of that specific neurogenic lower urinary tract dysfunction, and then understand the variable approaches to management. And maybe you'll feel inspired and want to join me in this, what I think is an exciting and challenging field. So when we think about the consequences of neurologic injury, I think the most pronounced ones we tend to think about are the musculoskeletal disorders and deficits, but certainly the things that I think we don't see as in society, maybe are private for the patient, are bladder dysfunction, bowel dysfunction, of course, some of the other sequelae. When we think about that from a clinical perspective, the true impact of the patient really impacts so much more than just what we see or what might be going on sort of underneath the surface. There's an impact on their independence and self-care, sense of self-worth, finances, their relationships. All these things are so devastated by the sequela of neurogenic dysfunction. And I think perhaps bladder dysfunction, as much as anything, has an impact or a negative impact on these sort of factors that are most relevant to patients. And so we have a real role to play in improving quality of life and helping to restore normalcy for our patients. My general principles of, I would say, urologic care. Number one, preserve kidney function to the extent that I can. Number two, limit infection. And I think that goes hand in hand with preserving kidney function and, of course, maximizing quality of life. Now, a lot of times all of these goals are in concert, but sometimes they're not. A patient may have a different idea about what maximizes their quality of life versus what I may think preserves their kidney function, for example. And sometimes we even have a differing opinion on what might maximize their quality of life, for example, in someone who doesn't want to catheterize, but probably would benefit from doing so. I want to briefly go over the physiology and to an extent the pathophysiology associated with the voiding process. It begins with conscious processing in the forebrain. That part of the brain decides around, looks at the environment and makes an assessment of whether it's an appropriate time to pee or an appropriate time to not be voiding. And then that sends a message to the brainstem where the pontine micturition or storage centers coordinate that conscious decision making so that the bladder neck, urethra, and pelvic floor all behave accordingly. The sympathetic nervous system then has a inhibitory effect on the bladder and a stimulatory effect on the bladder neck to promote urine storage. Parasympathetic nervous system, a promotional effect, excitatory effect on the bladder, inhibitory on the bladder neck, and then the sort of thing that we control, the somatic nervous system involved in bladder storage, has a stimulatory effect on the pelvic floor. Now that's a little bit of a sort of I wouldn't say it's a 40,000 foot view, but it's sort of a 4,000 foot view. But I think it's pretty much enough for us to understand how, when you start introducing defects in the nervous system, how that can negatively impact bladder function. Now we start introducing lesions. The patients ask, why am I having these problems? And what I tell them is that most of the time we think of the bladder as this a little bit of a boring storage vessel. Its job is to just kind of fill and empty. But in reality, you can see from all of this complex relationship that the sympathetic nervous system, parasympathetic, somatic nervous system all have to work in concert in order for storage and voiding to occur. And any of that gets thrown out of whack by an injury to any part of this nervous system, and you can really have a significant symptoms as a result of that. So you imagine if you have a lesion in the forebrain, an example of that might be stroke. You've got potential strokes in the brainstem region. You have suprasacral cord injuries, and then sacral cord injuries, or even peripheral pelvic nerve injuries. How that can very easily throw the system out of whack and cause fairly bothersome symptoms for patients. In reality, though, it's fairly simple, the pattern of injury that can result. On the bladder side, you can have overactivity, you could have underactivity, you could have both, of course, and altered compliance. All three can be present. As far as the bladder neck, you could have synergy, dyssynergy, or an open and slash incontinent sphincter. And then the same thing for the pelvic floor, synergic, dyssynergic, or open and incontinent. And the truth is, it's so important to define this in order to target therapy, but the only way to define it is with video urodynamics. As reliable as patterns of injury are, when we look at sort of papers that go through hundreds of patients, 80% of them with this type of injury may show this. The truth is, the only way to define what's going on and how it's abnormal and how really to treat it is by performing video urodynamics. So I want to mention what we have as our American Urologic Association and SUFU guidelines for urodynamics. There's one specifically for neurogenic bladder in the works, but for the moment, this is what we have from our societies. What's recommended in taking care of patients with neurogenic lower urinary tract dysfunction is that everybody gets an assessment of post-void residual, and then cystometrogram is useful for patients with relevant neurologic conditions. Now that's defined as high-risk conditions, generally spinal cord injury, multiple sclerosis, patients with significant deficits. We try to use fluoroscopy when available, and EMG should be performed, again, with grade B and C quality of evidence. Now, the truth is, if a patient with a significant neurologic injury, and as a sequela of that injury has bad urinary symptoms, shows up in your office, they're sort of by definition complicated, and it's very likely that performing urodynamics will be beneficial in that setting. For those patients, sort of regardless of whether they're in a quote-unquote high-risk category. They're seeing a urologist for a reason. They're bothered by their symptoms. There are a number of other societies that have produced guidelines on neurogenic lower urinary tract dysfunction. I list them here. If you're interested, I would recommend taking a look at some of these, and they provide a variety of different treatment recommendations, diagnosis, and workup as well for neurogenic lower urinary tract dysfunction, and are certainly worth your time if you're interested. So the first thing you need in order to perform video urodynamics is, of course, the equipment, but you also need a great team. So the equipment necessary is a C-arm and a fluoroscopic urodynamics chair. You've got a monitor over here that allows for picking up the fluoroscopic image, one for urodynamics, and again, you need a great team to help you run that equipment. Here's our nurse Kelly at Moss Rehab and our site supervisor Amanda, who volunteered to take this picture. Really a great group. It takes some time to invest and teach everybody and help them to understand why it's so important to get these studies. But I think once the knowledge starts to build amongst your team, they get really excited about the fact that you're doing it and what they're going to find on studies, and really invaluable. I'm so grateful for them. So let's jump into some cases, which I hope will illustrate the variety of pathology that you may see and management strategies as well. So I'll start with this patient, a young man. He had a fall from a ladder. He had a C6 incomplete spinal cord injury and came to me presenting with hesitancy, incomplete emptying, and urgency. Really remarkable guy, very committed to getting back to normal in every facet of his life, and to a large extent had done that when he came for urodynamic studies 7 months after his injury. So at that time, I performed urodynamics, and what we found is that he voided. He was telling me he was voiding on his own, not catheterizing, but he voided by terminal detrusor overactivity. So it was involuntary, the detrusor pressure started to rise, and then eventually he had some flow. So when you look at this sort of blown up, you can see he's got this sustained detrusor contraction. He's got lots of EMG activity associated with it, and a fairly low flow. Maybe he had a little flow back here, but it takes a while. So he's really not getting much bang for the buck, and he's not developing a volitional void. Now, this is where fluoroscopy is quite helpful as well. When we look at it, you can see that his bladder neck remains completely closed during voiding. So he's just got this abnormally elongated bladder, maybe a little trabeculation as well, and a bladder neck that's not opening, which can fit certainly with a cervical pattern of injury And it looks like based on his EMG activity that he's got some external sphincter dysuria potentially as well, but low flow limits to an extent our ability to see that. So I tried to convince him that he should catheterize. He didn't have upper tract changes then, but I was concerned that he was at risk for a problem as that I tried to convince him he should catheterize. I tried to convince him to take tamsulosin, and eventually he gave up on both. He came back to me 13 months later, so 20 months after his injury, and what we found was actually fairly interesting. At this time, quite a different study. He had, again, very happy with his symptoms. He said peeing on his own, not leaking, pretty happy with how he was doing, having not catheterized and no longer taking tamsulosin. But he had phasic detrusor overactivity, fairly high amplitude associated with EMG activity, so suggestive of potential persistent detrusor external sphincter dysuria. And then when you actually get to the end, he generates a volitional contraction. This truly was. I asked him to void, and he generated a volitional contraction. So we're now 20 months past his injury, and unlike prior when he couldn't do this, he now truly is developing and able to generate a volitional contraction. When you look at it a little closer, you can see that the flow starts a little bit earlier at the time of his detrusor contraction, and that also the bladder neck has an improved appearance. It funnels a little bit more, although it's hard to tell, but it looks like perhaps that sphincter is still not as open as we'd like. And certainly the flow, as denoted by this pink line, is still fairly substandard, below what we'd like it. So he's a patient, again, this is probably one of those circumstances where I thought maybe as far as protecting the upper tracts and optimizing his quality of life, that perhaps catheterizing, even being on medication, would be something that would protect him. But to him, that was counter to his quality of life goals. And so as much as I counsel him on that, he wants to continue to volitionally void and doesn't want to take medication, but he has agreed at least to close follow-up. So what is the data on volitional voiding and spinal cord injury? About a quarter to a third of patients will be voiding on their own 1 year after injury. And if you want to know which patients are doing that, it tends to be those who are younger. Women are more likely to be able to void on their own, and those with injuries lower in the spinal cord. So not those high thoracic and cervical injuries are less likely, and lower extremity motor function. So patients who walk into your office are going to be more likely to void on their own. Now, they may walk with assist or a walker, but the ones who are particularly debilitated are less likely to be able to do it. Now, quality of life. We think about the traditional teaching in terms of what's the risk to the upper tract in a patient who voids on their own. Well, we think that if they're Valsalva or Credang, that may transmit pressures to the upper tract, et cetera. But there are also other downstream effects from having to strain and push so much, like hemorrhoids, hernias, et cetera, that can certainly impact quality of life as well. But again, it's hard to convince patients who aren't using catheters and able to get their urine out that they should move in a different direction. Here we'll call case 2A. This is a patient who had urgency urinary incontinence, fecal incontinence, and incomplete emptying after a C7 spinal cord injury, incomplete. He's an Asia D, so he walks into the office, a little bit of a limp, but you wouldn't otherwise know he had a spinal cord injury, and he had a fall that caused that. So 3 years after his injury, for workup of these urinary symptoms, he underwent urodynamics, and what we found is that he voids primarily by terminal detrusor overactivity is part of the way he voids, but also does generate a volitional void. So let's sort of look at this a little closer. Again, terminal detrusor overactivity, some of the urine comes out in that context, probably explains his urgency urinary incontinence. And then as we zoom in on the voiding portion, we can see that he's got intermittent flow associated with increase in EMG activity. So nicely demonstrates that probably sphincter clamping down, as you see here, and unable to sustain a nice flow for that. So this explains the symptoms. It's always great when urodynamics fits with our symptom profile. Again, this is a gentleman who has terminal detrusor overactivity as well as external sphincter dysuria. So he ultimately elected to undergo sacral nerve stimulation. Catheters weren't an option for him. Botox scared him because of the likelihood for needing to catheterize for a high likelihood of retention. And so he went ahead with sacral nerve stimulation. Now, this showing the InterStim 2 system. We know we now have another system from Axonics that's rechargeable, and we've got another MRI compatible system that's expected from Medtronic in the near future. So that's great for our field. But I think to an extent, not having that MRI compatible device has limited how often we've been offering sacral nerve stimulation for patients with neurogenic lower urinary tract dysfunction. But it seems to work in the well-selected patient. Remember that when this technology, was being developed, it was originally developed in patients with neurogenic lower urinary tract dysfunction to try to reduce overactivity and to try to stimulate spontaneous voiding, again, in patients who had lost that due to injuries. When it goes in and it goes well, we're talking about test phase success rates, 50 to 70%, implant success rates, 80 to 90%, and then in limited study in spinal cord injury, we've seen up to 80% reduction in intermittent catheterization, significant reduction in overactivity and urgency leakage, and an increase in voided volume. Now, my own clinical experience with this is that patients who walk in the door for me are candidates for sacral nerve stimulation, provided they generate some sort of volitional void. Or urgency urinary incontinence is their primary issue, and they're really very much averse to catheterization with Botox. What I will say is that I think that although this data suggests that regaining of volitional voiding is of benefit, I'm not so sure. I'm not so sure that these patients volitional voiding is a benefit. I'm not so sure that these patients do as well as far as their reduction in catheterization, but more do well as far as urgency-related leakage. Right. So moving on to I would call case 2B. Okay, this is a patient, again, also not too dissimilar for presentation, urgency urinary incontinence and retention after spinal cord injury. This patient had a motor vehicle accident, young man. Despite the cervical level of his injury, he actually was more functionally paraplegic. His symptoms were quite severe. He reported symptoms of dysreflexia, urgency, and fear of leakage about every 1 to 2 hours. So we performed urodynamics for him at 3 years. On his actual urodynamics tracings, and we'll show his video images in a moment, he had increased EMG activity during very high amplitude detrusor overactivity contractions, pressures above 200 centimeters of water associated with leaks. So again, reproduced the symptoms fairly well. And then when you actually look at his video imaging, you can see that indeed, as the EMG suggested, he had external sphincter dysuria, a very dilated proximal urethra, and then a large right-sided bladder diverticulum. And so because he had failed antimuscarinics, he elected to undergo onabotulinum toxin A injection, 200 units, with significant improvement in his clinical symptoms. He went from catheterizing every 1 to 2 hours to every 4 to 6 hours. And I will tell you, in patients who are already catheterizing, onabotulinum toxin A is just remarkable as far as what it's done for the field. So looking at the data with onabotulinum toxin A injection, we have probably the best data we have is a 4-year total study combining North American and European data. And patients go from 4 leakage episodes per day at baseline, reduce that by 3.4 to 3.9 episodes across 4 years, and 100% reduction in over essentially half of patients lasting 9 months. It's really amazing what it's done for patients, and I see it improve quality of life so much. These are the ones, I think that if you look at the companies that make these medications, they're always wondering why their overactive bladder patients have such poor compliance with coming back for injections. I'll tell you, the patients who have neurogenic lower urinary tract dysfunction or catheterizing, their compliance is very good because it makes such a big difference for them in terms of their treatment. Sometimes you will see, talking about bladder compliance, not patient compliance, but sometimes you will see an improvement in compliance with this. So for patients who have concerning end-fill pressures, you might see a benefit there. Important to counsel patients who are not already catheterizing that about 1/3 of them will need to catheterize after onabotulinum toxin A injections. So certainly something that they'll want to know, and you'll want to counsel them beforehand. So moving on to our case number 3, this is a case of urgency urinary incontinence and incomplete emptying in a woman with multiple sclerosis. So very nice woman, all my patients are nice. That's why she can join the field. But another very nice woman, diagnosed with MS at the age of 35. So we're now about 20 years out. She had significant bother from hesitancy and urgency and urge leakage. And so we got urodynamics testing. The tracings are not quite as interesting as the VCUG images, but she had this marked dilation of the proximal urethra and detrusor external sphincter dyssynergia to explain her symptoms. In addition, she had a CT scan which demonstrated bilateral hydroureteronephrosis. So she actually has upper tract imaging, upper tract changes associated with these abnormalities. She couldn't catheterize. It wasn't something that was going to be feasible for her. And so she asked for anything I could possibly do for her to protect her kidneys and avoid the need for catheterization. So we went with the full-scale approach to try to avoid the need for catheterization and improve her upper tract findings. She went forward with PTNS to optimize her detrusor overactivity. With MS, I couldn't put a sacral nerve stimulation device in, not at that time at least. She took darafenacin, which she continues to take for overactivity as well, and then underwent sphincteric injection of onabotulinum toxin A. And fortunately, she had resolution of both her hydronephrosis and urgency-associated leakage. She's been very happy, and we do her repeat sphincteric injections and maintenance PTNS at regular intervals. So it's the data on tibial nerve stimulation. So again, this is another therapy. There are a lot more patients out there with overactive bladder, idiopathic overactive bladder, than there are with neurogenic overactive bladder. And so this is a technology or a therapy that's mainly marketed towards the 1 in 6 adults with overactive bladder. However, it can be successful in neurogenic lower urinary tract dysfunction as well. And there's really not a great reason why it can't be as successful or more, particularly patients who are walking into the office and don't have a huge level of disability. 40 to 100%, clearly it's not 100% successful. But MS, you may see subjective improvement in over 80% and resolution of urgency-associated leakage in 40 to 50%. We do find with most of these neuromodulation treatments that the frequency is a little harder to treat, but the urgency-associated leakage tends to get better. A nice role in Parkinson's and in stroke. These are patients who tend to be more debilitated. You may not be super excited about taking them to the operating room for a sacral nerve stimulation procedure. And then there's a questionable role in spinal cord injury, although again, I think we're probably going to be more likely to be excited about the sacral nerve stimulation in that field. Looking at external sphincter chemodenervation in neurogenic lower urinary tract dysfunction. It's typically done with 100-unit total injection, so 25 units each at the 12, 3, 6, and 9 positions. When I do it, I tend to use a hysteroscope. I found works really nicely for getting this nice visualization with the lens of the camera being out just at the front of the scope and allowing for injection. 4 injections. My success with this is mixed. I think that reflects the literature, whether it's mixed because I'm not always picking the right patients for it, or it's mixed because of the quality of injection varies, knowing exactly where the sphincter is from time to time. It certainly, I'd have to say that it's variable. But in this particular case, for this patient, it's worked fantastic. And I've had others it has as well. Other patients, it's been a little bit more disappointing. But we may not have any other great option. I would agree with this. The duration of therapy can be as much as 13 months. I'd say that's definitely on the high end, or as little as 2. I think if you commit to this type of treatment, you have to tell patients that you're thinking about a therapy that they're going to be getting every 3 to 6 months potentially, because it acts a little bit more like a peripheral muscle. They're going to their PM&R doctor every 3 months for Botox injections, and I would imagine we've got the same sort of pattern here. I would also counsel them about the risk of de novo stress urinary incontinence, which is about 5%. Let's talk about case number 4 now. This is a situation we unfortunately just see much too often. It's always so sad. So this is a 57-year-old woman. She was diagnosed with Guillain-Barré syndrome at age 35. That resulted in quadriplegia associated with this. And she had a chronic urethral cath. She was in a nursing facility, and then she developed an eroded catheter and eroded bladder neck and urethra with just continuous leakage as a result of it. So in discussing her options, she has decided to undergo a suprapubic catheter placement as well as placement of an overtight rectus sling. Now, unfortunately, she had persistent leak despite this. So being the urodynamicist, I wanted to just make sure that it wasn't because she had detrusor overactivity in a small capacity bladder, that it was potentially because of, not just because of intrinsic sphincter deficiency or failure of my sling for that reason. And what I found is that she had both intrinsic sphincter deficiency, you'll have to take my word for it on exam, as well as phasic bladder and rectal contractions that were associated with leakage and discomfort as well. So she really needed treatment of both. So we had planned for her a bladder neck closure and injection of onabotulinum toxin A into the bladder for treatment of this, as well as suprapubic catheter management. But this was postponed due to COVID, so we don't have pictures of that. However, I will encourage you, if you go back to this talk or you go to our slides, you can click this link. There's a great video on the AUA website, on the surgical video library, that shows the procedure that is my preferred procedure for doing a vaginal bladder neck closure. It's based off of Dr. Rovner's report, which I'll go over in a second. So first treatment for this patient was an obstructing pubovaginal sling. There's about a 75% success rate associated with this particular procedure in the literature. I think that's my experience. If you have about 1.5 centimeters, if you've got really any runway for placement of the sling, I think it's an option. I really like having the bladder neck to open. Suprapubic catheters clog, as any resident knows. Suprapubic catheters clog and need to be changed. And if you've closed the bladder neck, I think you've left the patient in a really hard position. Sometimes you don't have a choice, but I do like that as a first option before going to a bladder neck closure. Most of these patients who we're doing bladder neck closures on, as you're seeing here, they're fairly debilitated, oftentimes don't have the greatest social support, physically not in great shape, and so a vaginal approach to this procedure really saves on significant morbidity. Looking at Dr. Rovner's experience with this particular procedure, patients, 10 out of 11 patients were successful closures at about 10 months. But I will tell you that if this fails, or perhaps based on the anatomy as it lays out or your comfort, open and robotic approaches are also options as well for bladder neck closure. Usually like to get some momentum down if you can to support it, but certainly failure is possible with that. So moving on to case number 5. This is a patient with spina bifida who had retention with urgency urinary incontinence versus overflow leak. This was chronic for her, essentially since birth, managed with her parents. But more recently, she had developed pain and burning despite treatment of and rule out of infection. And she had cystoscopy performed with another urologist before seeing me. And so I didn't move right to cystoscopy right away, but I moved forward with video urodynamics. And on this, she had this sort of very low amplitude phasic detrusor overactivity that seemed to reproduce her pain, but the whole picture didn't quite fit. When she developed some hematuria, I ordered a CT urogram, which showed some stones in the bladder. And I thought perhaps this was the cause for some of her pain. But unfortunately, when I went in to do her cystoscopy procedure, what I found is she had a mass. I performed a transurethral resection of that mass, and it wound up being muscle invasive squamous cell carcinoma. So she had options for management, but truly this is a case where it became an oncology case, and she needed a radical cystectomy, which is what she went forward with. But what she chose, and she and her family chose, was to move forward with a totally robotic intracorporeal diversion as well, to try to limit her morbidity in the post-op period. So here on the left side of the screen, this is just a video of that operation that I did with one of my colleagues in oncology. And so let's just review for a second. Think about not just cystectomies for cancer, which we know is a morbid operation, but specifically in the neurogenic population. To some extent, our patients, I think, with neurogenic bladder are a little bit better off because they tend to be a little bit younger in general, tend to be a little bit younger perhaps, a little bit healthier than some of our patients in their 70s and 80s who are longtime smokers with bladder cancer. But still, we're talking about a 40 to 50% high-grade complication rate at 30 days. Nearly half of patients will require readmission shortly after discharge, within the first 30 to 90 days, certainly, of discharge. And we're still talking about a mortality of about 2%. So it's really a high-risk operation. But if they can get through it, if they can get through those initial 3 to 6 months of recovery, then patients really do have a sustained benefit in their urinary specific quality of life. Again, this is not an operation that anybody chooses to go through lightly. It's something certainly that asks a lot of them, it asks a lot of their family, but I think they really do come out better on the other end for those who recover well from it. Now, why robotic intracorporeal? So I think there's a lot of debate on this in the oncology world. Does robotic cystectomy really work? With improved ERAS protocols, even perhaps robotic versus open, there's not a huge benefit. But what I've really found is that in this patient population with neurogenic bowel, it has made a huge difference. I may have patients who, because of their neurogenic bowel and pain requirements after surgery with open cystectomy, maybe in the hospital for a month for no reason other than ileus that hangs around. Whereas my patients who get totally intracorporeal diversions, I've been very happy with how quick their recovery generally is relative to that. So perhaps in the non-neurogenic bowel, maybe less of a difference, but it really has been nice here. Supporting that sort of inclination that I have is a large series from Cleveland Clinic, not in neurogenic, I presume mostly oncology. Of course, Cleveland Clinic comes up, they've got 950 patients, with cystectomies and fairly equal numbers in both groups. But what they found looking at our intracorporeal diversion, extracorporeal diversion, and totally open procedures, what we found is that the intracorporeal seemed to have less blood loss, perhaps bias, but shorter hospitalization, lower rate of ileus, and a lower overall complication rate. So whether there's some selection bias in that, it's retrospective data, but I have found I really do enjoy it. And this is a patient who was very anxious and her pain was really minimal afterwards. So I think it's a really nice option to consider, and we all get well trained in robotics, and I think this is going to become the future, at least for neurogenic bladder. Last case number 6. So this is a really quite challenging situation. 65-year-old gentleman with a T10 complete spinal cord injury he sustained in a skiing accident when he was 34. He initially was doing intermittent catheterization, had to stop for some reason, couldn't quite remember why. Ultimately had a suprapubic tube placed because of the catheter erosion, and then continued to leak despite having a urethral bulking injection. So tracings for him really weren't worth looking at, but his video urodynamics image showed that it filled him with 30 cc's and he just leaked right out with a wide open bladder neck. So I think clearly the easiest answer for him in terms of having him not leak anymore, he already had a colostomy, perhaps we could do a no bowel anastomosis, simple cystectomy, and get him out of the hospital pretty quickly. But he was really adamant that he wanted a reconstructive option that would not require him to have another continuous drainage. He didn't like his colostomy and didn't want to have another one of those on the urinary side. And so here it is, just the arrow showing his floridly open bladder neck. And so he elected for an open ileocecal augment. Now, this wide open bladder neck, we had to address that, because if you augment him, you can make his bladder as big as you want, don't have to worry about detrusor overactivity, but he'll just leak. As soon as the bladder fills, he will leak. And so even though catheter erosion, we see it more commonly in women, I absolutely will see it in men too. In those circumstances, if they want an augment, it really makes it a lot more challenging. So let's just talk a minute about augmentation cystoplasty. On the right is this quickly moving pictures through his particular surgery, which we'll talk about in just a second. I prefer the ileocecal augment, probably to a large extent. It's because of my comfort level from making Indiana pouches for malignancy, so it's just familiar to me. But also I really do think that the goal here is to make the bladder bigger. It achieves that goal. And the goal is to achieve continence as far as the stoma. And lastly, the goal is to not have to reoperate on the patient because of stenosis at the skin level, which I think is probably one of the most common reasons people undergo reoperations after catheterizable channel creation. And I think this probably achieves all of those goals the best. About 95% of patients will be continent through their stoma. Capacity increases very nicely with about a 10 centimeter or so segment of right colon. And then when you look at it, there seems to be the lowest rate of stenosis for non-reconfigured ileum when you look at the various types of catheterizable channels. And you talk about appendix and in adults with big abdominal walls, it's certainly a hard option to use in that population. Now, in this patient and in other patients, you have to consider whether you need to treat the outlet, as we were saying. And I don't think there's a great universal protocol for what to do for the outlet. In men, it's especially tough. I think in women, you can do slings, and it's pretty straightforward. Particularly if you're doing this surgery, it's pretty straightforward to add a vaginal approach to a sling, or even a bladder neck sling to it that works nicely, but not so much in med. So as we kind of move through these, I'll pause that a second. Here you have just the isolated bowel segment. We've got our bowel anastomosis here. I think a couple views of that. We've got our clamshell bladder getting ready for us to sew the augment down into it. And then we've got our tapered catheterizable channel. We've got our measuring tape around the bladder neck. Here's our bladder neck artificial urinary sphincter in position. And then I believe this is showing where our tubing is going after we've tunneled it. And these are final images. Here's a Provena wound vac. I think if you look at the picture before, you can see one of the things that probably makes you most paranoid is having open colon and then putting a foreign body in there. But we actually use a Provena wound vac and then some prayer to avoid infection in these circumstances. Are very, very careful with washout technique and antibiotic irrigation. And you hope, but at some point that'll be a challenge that patients have to risk. And here's the final appearance. There's a colostomy cath channel, and then going from there. So as far as the other considerations in the long term with ileocecal augment, so let's say you get through the procedure and the patient does, great, and I'll just play that, and the patient does great, you still, can't high five in the long term because these patients have a lot of maintenance, and they have to know that and be counseled accordingly before you go into this treatment. What I tell patients is that the ideal person for this operation already knows how to catheterize and can't for some reason. So because in men, that's usually a stricture, but it's not right for everybody. And that's certainly important. Patients who can't catheterize themselves, I think it's really hard. It's harder. You're not necessarily setting them up for success unless they have a really, really reliable, great support system. Malignancy risk is there. It's highly variable in the literature, but something to think about. It certainly increases over the course of time. We're talking about 10 to 15 years out. I think ileocecal augments don't seem to be at necessarily higher risk than other forms of augments as far as cancer risk. The 11-year risk of secondary surgery and long-term series is about 40–50%. So patients are going to be back in the operating room, whether it's for stomal stenosis or another reason. Probably the most common reason is because of bladder stones. But then that dreaded complication, the emergency complication of a bladder perforation, may happen in as many as 10% of patients. So certainly important to counsel as far as that as well. Right. So those are all the cases I have. I hope what I've convinced you as we've gone through these cases is that video urodynamics is critically important in the diagnosis and management in patients with neurogenic lower urinary tract dysfunction. I hope you see that I don't think I could decide really for any of those patients exactly what to offer them and how to proceed without video urodynamics. But I will say as an aside, I think there's a lot of classic teaching, which is great from all the incredible work that Dr. McGarry did in the 80s on kids with spina bifida, about leak point pressures and upper tract deterioration. The challenge is in adults, I don't think that video urodynamics is so super reliable at assessing risk of upper tract deterioration. I think to some extent, you see upper tract deterioration and high-risk features and you figure they go together, which they probably do. But I have a lot of patients with very quote-unquote high-risk features that don't have upper tract changes. And for this, if you're interested in a little bit more of seeing what the data is out there on this particular topic, there is a systematic review and meta-analysis that was done over the last year in neurourology and urodynamics, which touches on that topic specifically. Again, treatment for patients has to be individualized according to their upper tract risk, although again, that's a little bit harder to assess. Of course, their bother and their willingness to undergo risk in order to improve that bother, and the specific pathophysiology that we identify on video urodynamics. I want to quickly, before I finish, I think I'm on time, I want to thank Dr. Hampson. I don't know whether she's watching this one, but maybe I'll have her watch this. I don't want to embarrass her too much. Dr. Hampson and I met in medical school. I had the privilege of meeting her in medical school, and then the privilege of also going through all of my clinical rotations with her, joining and matching in urology with her, and also Dr. Borowski, another one of these lecturers from earlier. in the sequence. And it was really a privilege to get to know her in medical school and continue to be friends with her over the years. I'm impressed, but not surprised. She continues to excel as a surgeon, certainly as a friend. She's always been great. And now she's excelling as a mom as well, somehow doing it all. So she's really great. And I'm grateful she's put this together and given me the opportunity to speak to you. I ask you for questions. Before I do, I want to thank all that you do. Thank you guys for all that you do as residents. You're the true, backbone. Forgive me for making a dad joke in a neurogenic bladder lecture. You're the true backbone of care in academic medicine. It's a lot of sacrifice, I think, from everyone, but we know that the residents are just doing so much. And what I say as an attending in an academic program is that I know we're committed to hopefully keeping you safe, always hopefully letting you know how much we appreciate what you do, both in this time of crisis and other times as well. So thank you. My email is here, it's listed. Please feel free to send me emails if you don't have a question get answered during the Q&A, or if you're someone who's watching us after the fact. I'm always happy to take emails and feedback. And then I think there's one last slide that I'm supposed to keep up here so you can review it.
Great. Thank you for a great talk, as always, Josh. There are a few questions that came in as you were lecturing. The first two had to do with Botox. What's your experience with Botox into the external sphincter alone for detrusor external sphincter dyssynergia? And then after that, how about your thoughts on Trigone injection?
Oh, sure. So I'll take it for a detrusor for sphincter injection alone. Most of the patients that I've used external sphincter Botox in, we have a fairly big, through Moss Rehab, anoxic brain injury and traumatic brain injury population. And those patients have a little bit of a pseudo dyssynergia type picture. And so I'm using it in them because many times they're not emptying their bladder completely. They don't like being catheterized as much. And so we're trying to decrease the sort of frequency of how often they've been catheterized. And not so much in the spinal cord MS population. That's actually one of the exceptions to the rule as far as that. My experience is it's okay. It's a little disappointing. I haven't been able to take anybody from being catheterized 3 or 4 times a day to not needing catheterization. I have been able to take some people down from 3 or 4 to maybe 1 or 2. That's where I find I get the benefit. I have a couple patients that I've put sacral nerve stimulation devices in and done external sphincter botulinum toxin, and I think that it does something because we're trying to reduce their UTIs and catheterization frequency, but not as many home runs with that approach. And again, also they're in the operating room every potentially 6 months or more, which I think limits its efficacy. And it's probably why it's not my first choice, despite some promising data in that regard. And second is for trigonal onabotulinum toxin A injection. I think that's where most of the nerves are concentrated in neurogenics. In neurogenic lower urinary tract dysfunction, I tend not to concentrate my injection there because I really think we're trying to sort of treat the detrusor muscle. But certainly in pelvic pain and interstitial cystitis and bladder pain syndrome, there's a lot of good evidence that onabotulinum toxin A in the trigone really targets the sensory nerves and frequency. And so I have patients who are more bothered by pain or frequency component. I do target it there, and I may do, if I'm doing 10 injections, for example, I may try to put 7 of them in the trigone and see how that works. And I've had success with that in that specific population.
Great. Next question is, are you doing PTNS implants in the office? What do you see the role of that being moving forward?
Yeah, so I'm working on getting involved with a company for a trial for PTNS implants. But I'm so excited for that technology. There are so many wonderful technologies that are in the works right now. Just to briefly run through, there's something called Cohn, which it's an implant that goes into over the tibial nerve that gets implanted, and that runs on a cycle, automatically. I believe it's twice a week, so it sort of takes you through the PTNS usual, maintenance and an induction course through that automatically. There are several other implants that you wind up wearing an ankle brace once a night. And so the idea there is that instead of being able to get a sort of dose of tibial nerve stimulation, you get that dose on a nightly basis. You don't have to come back just once a month for maintenance. You can do maintenance as often as you think you need to. It's a very exciting space. When you're in practice and you're talking to patients about having a device put in their buttocks to then go to their sacral nerve and have something implanted, they really look at you funny. And then honestly, some of them look at you pretty funny when you tell them you're going to bring them to the office every week for 12 weeks in a row, and then potentially once a month thereafter. And so I think it's when we get that as an option that we can introduce into clinical practice, it's gonna work. It's gonna work. It may work better, but I'm very excited for that. In general, tibial nerve stimulation, if you look across the studies, almost no matter what the sort of dosing or approach, you get about a 70% response rate across the board. And I think we'll see similar, maybe a little better since we can increase the dose on it, but compliance with therapy will go up.
Yeah, that will be an exciting thing to look at. The next question was about slings. If a patient with a sling already has a sling in place with continued leakage, do you do a sling revision primarily, or will you attempt salvage bulking in those patients?
So it depends. It depends on how badly they're leaking, and what kind of sling. I think a lot of times the sling question comes up as maybe a patient who has a midurethral. So this was talking about specifically a pubovaginal sling, a rectus fascia sling that was intentionally tied over tight. So I mean, you talk about 2 or 3 finger breaths in the non-neurogenic population when you're not really trying to obstruct. For this, you probably tie about 1 finger breath, above the fascia for an overtight sling, and you take a look at the cystoscopy and take a look. If they're not leaking that much, if it's not florid, I would try bulking agent because you really don't have a lot to lose. Looking at the midurethral sling population, or sort of a more traditional sling procedure frankly for men with post-prostatectomy incontinence, we're talking about potentially an 80% salvage rate. I've had good success with injecting bulking agent. I've expanded the use of bulking agent in men, kind of for similar presentation, even if they haven't had treatment yet, and I've been happy with it, and certainly the same for women as well. So I don't think you have a lot to lose by trying it. Unless you really just think you're going to be wasting an operation.
Great. And then there's kind of 2 more questions to go, both regarding your cystectomies. To start, in your simple cystectomies, is there a reliable way that you try to identify patients who may have a more difficult immediate post-op course? For example, many of younger patients may not have the same medical comorbidities as your older cohorts.
That's a great question. I think everybody can potentially have a hard post-operative course. It's a hard operation. Certainly there are some patients who have a greater degree of comorbidities, and those patients are at a greater risk. But I will tell you that everybody's got to be prepared for a hard road. And if you get lucky and everything, all the stitches, you put all the stitches where you want, and if things go great and they get out of the hospital, in 7 days, and everybody's, smiling and happy, that's fantastic. But they all have to be prepared for the other scenario that all of us see when we take care of cystectomies.
And then many neurogenic bladder patients are malnourished. Does this change your approach to wound closure or removal of drains and staples?
Yes, I'm a little more conservative with that, with pulling drains and staples out. I don't rush. I think I take it on a case by case basis, but I try to pull drains out after I pull the stents out of them, going to pull them out, when they're in the hospital. Those are usually for patients who may be there for more than the 2 weeks. I usually would leave stents in, but I leave staples in a little bit longer in a malnourished population. We try getting them with preconditioning on boost, to optimize their nutrition ahead of time. There's some evidence that can help, at least more in the colorectal world than urology, but certainly can help. I don't think we've talked about preconditioning, I think, in radical cystectomy for actual physical sort of rehabilitation beforehand. And that's really hard when patients are, quadriplegic, but you can optimize their nutrition otherwise.
Great. And then one last question just came in. What has your experience been with neurostimulation in your neurogenic bladder patients?
Yeah, so another thing I'm super excited about. I think that our use of neuromodulation has been limited. Part of it is marketing. Again, a lot more patients with overactive bladder out there than neurogenic bladder. So it makes sense that if you're a company trying to, have as many of these put in as possible, you're going to market it for overactive bladder. And the truth is, it works great for a lot of patients with overactive bladder. But in neurogenics, it's a really desperate group without, a potential better option. By the time I get to neuromodulation in many of these patients, their next option is truly not just living with their symptoms, it's cystectomy or augment, which is a way bigger step. And so the only way to know if it's going to work is to try it. Now, some patients, it's just silly to try, who are really debilitated. There's no way they can manage their device. They don't have the support system to even try to manage it. But for any patient who comes into your office under their own power, has either a family member or a good support system in place, even if they can't manage the device themselves, that can help them, and is willing to undergo that operation, I'll try. And again, my experience is less, despite some of the promising data that came from otherwise from outside, my experience is less that it improves emptying, but it does a really quite nice job with improving the urgency and urge-associated leakage. So.
Awesome. Well, I think that wraps up our questions. I was asked to remind everyone that the 10:10 a.m. lecture is canceled due to an unforeseen schedule conflict. Dr. Wien's lecture on overactive bladder and lower urinary tract dysfunction has been rescheduled to June. And thank you again for your understanding in this matter. And to remember to evaluate the lecture so we can continue to improve these lectures as we go along.
All right. Thanks, Dr. McGarry. Appreciate it. Thanks,
Great.
everybody, for coming.
Thanks again.